Morning, everyone, and in this lecture, this is the second part of the lecture of SLE. And in this one, what we are going to do, we are going to talk about the investigations as well as the management of SLE. So, to start with the investigations, okay, of course, or you can say the diagnosis of SLE. Uh, One thing, which can be said about SLE is simply think about SLE when anyone have two or more than two organ systems are involved. Okay, anyone who have two or more than two organ systems are involved, think about SLE. Um, as you know, what you can say, we have someone with a butterfly rash, of course, uh, or any of these things, any of the system is involved, we can think of SLE. One of the things which I wanted to show you, though it's not important that you must remember that, is the diagnostic criteria for, you can say, systemic lupus erythematosus. So, as I told you, malar rash, discoid rash, um, like this is how the discoid rash looks like, photosensitivity, oral ulcers, arthritis, serositis, renal disorder, neurological disorder, hematological disorder, immunological disorder. We will discuss, of course, these things, anti-nuclear antibodies. So now they say if four of these criteria well documented are present at any time in a patient history, the diagnosis is likely to be SLE. Specificity is 85% and sensitivity is 95%. Okay, so we had discussed all these things, right? But we have to discuss this part now. Talking about the lab diagnosis, okay, of the patient with SLE. Okay, now we are going to talk. I'm not going in that way that I will talk about the autoantibodies. Rather, I'm starting with a routine blood test. So CBC can be done, and you can see over here they will show leukopenia and thrombocytopenia, and of course they will show the anemia of chronic disease. You can say the anemia of chronic disease will be there, right? Anemia of chronic disease. Okay, anemia of chronic disease. And of course, like in hematology, we know already what is anemia of chronic disease. So now, what happened, like, it's an autoimmune disorder. So, of course, what happens is they may have hemolytic anemia. So, we can do the Coombs test. I have discussed this thing as well. So, simply we do the Coombs test and, it come back as positive as well. Okay. What are the other investigations or lab diagnostic tests we can do is, uh, wait, um, yes, we can check the ESR and we can check the CRP. So now CRP is usually elevated, especially when the patient have some inflammation going on like arthritis or pruritus and things like this. Okay, so we can do ESR and CRP as well. Other than that, what we can do is we can check the blood urea nitrogen. Okay, of course, because the renal involvement is there. We can check the cholesterol level because they can be elevated secondary to nephritic syndrome. Okay, we can check the transaminases level, which can be elevated due to hepatitis. It can damage the liver as well. We can check the creatinine kinase as well to check for myositis, right? So all these things, they are pointing towards inflammation of the same thing. We can do urine analysis. Of course, the patient can present with hematuria, protein urea, and when there will be protein urea in the urine, so you can add one more thing, um, albumin anemia. Okay, so of course, like they present with albuminemia. So, and we can check for the cast of leukocyte or the erythrocyte. Okay, now this thing is quite understandable. not I don't think so, like it's difficult to understand why we are doing this thing, because the renal involvement is there, right? So now let's talk about the autoantibodies. The first autoantibody which we are going to talk about is um, there are many autoantibodies which can be present in the SLE. First of all, ANA or anti-nuclear antibody. They are highly sensitive. Okay, by the way, you can change it to 98%. Okay, so they are highly sensitive, but the specificity is not that much high. So that's why, remember, when the sensitivity is too high, so it can be used as a screening test. Okay. So this thing, because 20% of the healthy young women also have positive ANA, the presence of ANA alone is not given much weight. Or high titers are more indicative of a connective tissue disease of some sort. Okay. Remember one more point about this one. It is not useful to follow the course of the condition, course of the disease. Like if it is raised, it doesn't mean like the patient condition is bad. Simply, okay. If it is raised, it doesn't mean the patient condition is bad. So this is about anti-nuclear antibody. Okay. There are many others. For example, anti-double-stranded, anti-dsDNA. Now, anti-dsDNA and one more, which is anti-SM. Okay. They both are specific. You can see the specificity 95%. See the specificity 99%. Okay. So they are highly specific, anti-dsDNA and anti-SM. And it is associated with more severe lupus, kidney disease association, and diffuse proliferation, glomerulonephritis, and central nervous system, cardiac and pulmonary also associated. So when they are higher, the condition is bad. And the anti-SM, again, they are more specific. Okay, they are more specific. They may have anti-RO or anti-LA. And if you are going to hear my lecture of autoantibodies, you would understand what are they. Anti-LASSB is also associated with what? Sjogren syndrome. Okay. Other things, now anti-RNP can be present. My next lecture will be about antiphospholipid antibody. Okay. So we are going to discuss this thing in the next lecture because they will develop antiphospholipid antibody syndrome. Talking about the serum complement levels, guys. The serum complement levels are often reduced, especially C3 and C4. Okay. And when they are reduced, it means like there is active SLE. Okay. So simply, the important thing over here is, I would add one more slide here. You can say the combination of high ESR high ESR, high anti-DS-DNA and low C3 shows that it's a flare-up disease. Or you can say it's an active or disease, right? Or more damaging disease, you can say. So as soon as the disease activity is controlled, these things go back to normal. Okay. So That's the important thing in these patients. Okay, for these one. So all these things, we can do this one. Okay, so not just C3, you can say C4 also. Okay, so C3 and I would and C4, they all fluctuate with the disease activity. Okay, skin biopsy can be done, and we have already talked about uh, like this is immunofluorescent what they are doing over here, and you can see like there is deposition of immunoglobulins or IgGs in the skin and in the kidneys. So it is helpful in diagnosis of SLE cutaneous lesion. This is lupus band test. This is renal biopsy. Okay, and imagings can be done like X-ray, CT, MRI. See X-ray of the hand, CT scan of the chest, MRI of the chest, so or MRI of the brain. Okay, so all this tests can be done. CT scan of the brain can be done, which can show the infarcts. MRI of the brain can be done, which will show the changes in the white matter. So all this tests, they can help you to tell the course of the disease or like how the disease is behaving. So these are all the investigations, to diagnose SLE. And I already show you this thing. I already show you the diagnostic criteria for systemic lupus erythematosus. So of course, like the differential diagnosis will be a very, very, very long list because it is a multi-system disorder. So guys, remember it affects a lot of systems. So of course, this one will be having a long list of you can say differential diagnosis. Treatment of SLE. Now, guys, it's a multi-system disorder. It's a chronic condition, right? So of course. There are different, you can say, strategies which are played in this one. For example, we actually have to define some goals. Okay, how to treat this condition. We have to go for sometimes symptomatic management. So simply, treatment depends either it's a non-life threatening SLE or life threatening SLE, or it is a lupus crisis. So what are the general principles? Um, Patients with SLE usually need more than normal rest. Ultraviolet light should be avoided. Stress, including surgery, infection, childbirth, abortions, and psychological pressures, may exacerbate the condition. Okay. Okay. Now, of course, the goals of the treatment is to treat uh, the early condition and avoid long-term use of steroids. Okay, because steroids have side effects. So sometimes, of course, when we have to give steroids, we can use, and there are side effects, we can use steroid sparing drugs. And the important thing is to treat any exacerbation of the condition. SLE patients who are not stable should be followed quarterly for routine physical and lab monitoring. SLE patients taking glucocorticoids should have a screening bone density scan because glucocorticoids or steroids causes osteoporosis. That's why we go do bone density scanning. Patient with SLE should avoid sulfonamide antibiotics, which can be associated with disease flare up. And oral contraceptives and estrogen replacement therapy are contraindicated in patients with SLE. So, what are the drugs we can use? We can use NSAIDs, okay? We can use glucocorticoids, especially in um, organ threatening disease. We can use hydroxychloroquine. This one improve the long-term control and prevent flare-ups. We can use steroid-sparing drugs like cyclophosphamide. Okay, especially we can give IV cyclophosphamide for serious organ involvement, like someone who is having lupus nephritis or cerebritis. We can use methotrexate or methotrexate. MTX is the short form for methotrexate. We can use azathioprine. We can use cyclosporin. We can use mycophenolate, mofetil. This is the uh, short form. So all these drugs are what? Like these are steroid sparing drugs, guys. Nothing more than that, right? So basically, what they do, um, whenever there is inflammation, they give NSAIDs. Okay, they give hydroxychloroquine, and they give corticosteroids. Okay, for organ threatening condition, can be given IV in severe disease, and this is the side effects of corticosteroids. They can give cyclophosphamide. Okay, um, for the disease flare-ups, or cyclophosphamide can also be given IV whenever there is any serious organ damage. This is the toxicities of cyclophosphamide. Methotrexate can be given. It's a steroid-sparing drug, and this is again like the toxicities of what the side effects of methotrexate. Other immunosuppressive drugs. Okay, I will remove that Chinese medicine because this one is like not mentioned in the books. Um, if the disease is non-life threatening, so this is like all the life threatening treatment, guys, which I show you, right? So if the disease is non-life threatening, then we have to avoid the sun, use sunblocks. Okay, avoid UV light. Okay, avoid UV light in these patients. Okay, and simply um, hydroxychloroquine is used to treat photosensitive rashes. Topical, topical, topical anti-malarial, topical form. Topical means like you're going to just apply on the rash. So all these things can be used, right? Whenever there is arthritis, you can use NSAIDs or hydroxychloroquine. Okay, and anyone who have non-life-threatening lupus, so we have to control the hypertension and dialysis, renal transplantation. Consider for that, and again the same thing. Like the details of that thing, I'm not interested in going in details. If you are interested, of course you can go and read that. Okay, because you don't, like no one is going to ask this thing, guys. No one is going to ask you, like, if the someone have stage 4 lupus nephritis, what is the treatment? No, you must know, like, there is lupus nephritis, and you must know like what drugs can be used for SLE. That's it. Okay, so of course I'm scrolling down the slides just for you guys to go through that. Okay, if you are interested, of course. Okay, otherwise of course there is no need. um, One thing, I would like to mention, by the way, before ending up the lecture, is the newer methods. Nowadays, they are developing new medications. Okay, for example, rituximab, which is a anti-CD20 drug. Rituximab. This one is like rituximab. It is an anti-CD20 drug. So these newer drugs are also in development. Okay, not development, they are already developed but expensive. Okay, so um, they are also making so all these kind of drugs. So simply, guys, this is a flowchart: treatment for non-life threatening non-life or organ threatening, and treatment for life or organ threatening. So see, in non-threatening, quality of life acceptable, conservative management. Quality of life is not acceptable, low dose glucocorticoids. But anyone who have a life threatening, high dose glucocorticoids, with addition of the second drug like cyclophosphamide or mycophenolate, mofetil, or after response like discontinue cyclophosphamide but maintain this one, or azathioprine. If there is no response, we can go for some experimental therapy. If there is a response, so taper off the dose, stop them. So this is how it goes. Um, Other than that, if we will talk about the complications of SLE, or the prognosis of the SLE. Uh, Most of the major cause of the deaths in SLE is accelerated atherosclerosis, renal failure, or CNS lupus when it is affecting the CNS or infection. So now SLE behave like in a you can say um, exacerbations and remissions way, right? There is exacerbation, there is a remission. There is exacerbation, there is remission. So our target is to reduce the exacerbation and achieve remission over a long period of time. Okay. Uh, Nowadays, the mortality of SLE is decreasing. Okay, because of newer drugs, better treatment options are available, and the death is mostly like as I told you. I show you what are the causes of death, right? Already. Um, like of course like the joint problems are there, but they cannot cause the death. Like of course it is the vital organ failure which causes the death, right? um, so that thing is the important point to remember, right? um, this one talks about how can lupus affect pregnancy or the newborn. So fertility is normal, in the patients who have systemic lupus erythematosus. Okay. um, Recurrent miscarriages are common, but in the patients who have antiphospholipid syndrome, which is my next lecture, as I told you. So they have like spontaneous abortions. Okay, in that case, many women when they get pregnant, they have exacerbation of the condition, but many don't. Okay. Um, One of the thing, guys, I would like to talk about in pregnancy is it's a very favorite question. I don't know, not about PLAB or USMLE, but of course, like in exams like MRCP, they do ask questions like this that you know whenever anyone have NTRO or NTLA, NTRO or NTLA positive antibodies, they have increased chances of stillbirths as well as uh, births and fetal heart block. Okay, so this is a very 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 like you can say important question um, regarding this one. Prognosis: early death in SLE tend to reflect disease activity. Late deaths are largely due to cardiovascular complication and lupus nephritis. Okay, I told you over the past few decades that things are becoming better in SLE. Okay, and so anyhow, guys, like okay, from where I took this. This one is taken from Kaplan's. In Kaplan's, exactly if you will open the Kaplan, you will find the same questions, right? They give this one. Very easy to answer. If you heard this lecture carefully, you can answer them very, very, very quickly. The best screening test will be which one? A positive ANS supports a diagnosis but is not specific for SLE. It's wrong or right. The dash and dash are specific antibody for lupus. I answered this thing. Complement level C3 or C4 or more sensitive CH50 are dash in patients with active lupus. So you have to tell either it's decreased or increased. Elevated levels of dsDNA are seen in that active lupus. I answered this thing during the lecture, right? So I took it from what you can say, Kaplan's. Diagnostic criteria again, we need 4 or more of 11 must be present. Um, Butterfly rash is very, very, very common. 1. Arthritis is very, very, very common. 2. Okay. Number third, see, hematological, you found 3 and you found ANA positive 4. So 4 criteria are met. Done. 4, 7, 11 rule. 4 out of 11 criteria. 4 labs, 7 clinical. So there are 4 labs, 7 clinical criteria. I hope you guys understand, guys. I don't think so. Like SLE can be made easier than this lecture, Very easy approach, very, very, very easy approach to understand this condition. It's not hard. So why it is called as 4, 7, 11 rule? Because there is total 11 criteria. Out of them, 4 are lab criteria, 7 are clinical criteria, and we need overall 4 or more to diagnose someone with SLE. Again, the same thing, but this is a simple other criteria. No need to remember. SLICC classification criteria for SLE. So, anyhow, guys, I told you all the conditions in which, sorry, the spelling mistake, all the conditions, in which there is too much sign and symptoms, they have a lot of differential diagnosis. These are all the differential diagnosis. We will cover this one, systemic sclerosis, in one lecture. Sjogren's syndrome, I already told you what is that. Mixed connective tissue disease, maybe I will cover. In one lecture, we will cover dermatomyositis and polymyositis, malignancies, so Behçet's disease, drug-induced lupus. What is positive? Anti-histone antibodies, I told you, right? And lupus can do anything. So thank you so much, guys, for listening. I hope you understand. I will see you in the next lecture. Thank you so much.